Hey, good morning, everybody. Thanks for joining us today. On our program today, we're going to have a really special guest, someone who's made a lot of impact in the world, both in my life and in the life of many patients. So before we get started, I just wanted to say I appreciate you guys visiting with us today. If you like what we're doing here, like us on Facebook, share this with other people so that we can continue to get the message out. And to start with, I wanted to tell a quick little story about today's guest. When I got out of medical school and went to residency, I sort of went into practice, and I realized that there were so many people that were suffering, and I didn't quite understand what was going on, but I knew there were answers out there. So I reached out to some people, and this particular person welcomed me into their office immediately and really started me down the path of being able to help other people who previously I might not have known how to help. So I really appreciate that. So today's guest is Dr. Richard Horowitz. He is the New York Times bestselling author of Why Can't I Get Better? And also he's the nationwide bestselling author of the follow-up updated version of How Can I Get Better? And so without further ado, I wanted to welcome Dr. Richard Horowitz. Morning, Rich.
Good morning, Tom. Good to see you.
Same here. So I appreciate you taking the time to join us today. You know, you and I have spent a lot of time talking over the years, and I appreciate all the time that you've always spent to answer my questions so that we can help others. And, you know, I think the thing for me that really stands out with your approach is that the number one thing is always the patient and alleviating their suffering. Anything from the books you're doing to the lectures and stuff. So I was hoping you could tell folks a little bit about what's coming up in the near future for you, and then we can sort of talk about the newest paper you published.
Sure. So I'm going to be the keynote speaker at the Second World Immunology Conference in Chicago, Illinois, next month between October 9th and 11th. Then I will be at ILADS in the Boston area with you. I know you're going to be speaking also, so we'll be there in November. And then I'm finishing off the lecture series in December. I don't do too many 3-day weekend workshops, but I'll be doing a second and last. But this is one of the few times I can actually take a full weekend and go over the literature. It's a continuous question and answer. We have fun. There's an evening of meditation and singing and healing circles. I mean, it's just a great experience. So for people that can make the Kripalu in December, it's a great opportunity to figure out why you can't get better, and for doctors and healthcare practitioners to be able to kind of hone their skills a bit so they can help their patients.
Well, fantastic. I'm not sure what happened. On my end, I had a little bit of a tech cutout, but it sounds like you've been going just fine. So I hope we'll rehash some of those things at the end to be sure. So, you know, one of the things that I think is really complicated out there is, you know, the question of what's Lyme and what's not Lyme. And I think you tackle those pretty extensively in your books. But more recently, you know, you just published a paper validating your questionnaire, and so love to hear you tell us a little bit more about what that's about and what you guys found.
So we've been working on this paper for 3 years. This is a great celebration for us, for Dr. Phyllis Freeman, who's senior researcher at the Hudson Valley Healing Arts Center, and Dr. Marielle Satera, who's at she's a PhD who's at the State University of New Paltz in New York. And we've been working on this paper for several years, and the reason we felt it was important is because you and I both know, and as all do the Lyme patients who are out there, is that we don't have sensitive and specific testing for this disease. There's over 100 different strains of borreliosis worldwide. Generally, the lab tests are looking at one strain, like the B31, except for labs like IGeneX that are using 2, like the 297. But the problem is, you know, you have someone come into your office, they have fatigue, they have aches and pains, they may have memory and concentration problems, difficulty sleeping, psychiatric problems, and you ask yourself, well, does this person have Lyme Or do they have an autoimmune disease? Do they have some other disorder? So the first step has to be to figure out whether it really is Lyme. And up until now, I think what most of us have been doing is, we've been using some of the symptom questionnaires. There have been ones that have been out there for a while. Dr. Joseph Borscano, who was one of my mentors years ago, just like I was happy to, share things with you. Of course, Joe is a good friend of mine, and he had a questionnaire, but the questionnaire was never validated. So what we did is we thought, well, we've got all these laboratory tests that are out there, and people are confused on how to use them. And you and I will go through that a little bit today of what's a logical way of really testing people for this disease. But, the first step in a worldwide epidemic is you have to have some validated, inexpensive screening tool for checking people. So we worked on this questionnaire, and one of the first things I did years ago is we started adding scores to the questionnaire, and we had two forms of it. One was mild, moderate, and severe, so both the intensity of symptoms, and then we had another version that was the frequency of symptoms. It turned out that actually both of them started working actually when we started testing it. But when we did our first book, Why Can't I Get Better, we had only validated it in 100 people in my medical office. And at that point in time, the scoring on the questionnaire was, anything that was greater than the mid-40s, you had a high probability of having Lyme. Well, what we did in this case is we went to the Lyme groups, and I posted this on Facebook. This was about 3 years ago, actually, we did this. And I want to thank, the Lyme groups like LDA.org, LymeDisease.org, Bay Area Lyme Foundation. Many of the Lyme groups posted a Survey Monkey on Facebook, on their sites, and we basically got around 1,600 people to do this. We also had colleagues in 2 other medical practices in Vermont, and one in Vermont and one in Connecticut. And so we had patients from different medical practices, an online survey, and we gave out the questionnaire, and basically we validated the questionnaire in these 1,600 people, and we did several studies. So there were 3 studies. Study 1 examined, when we did this paper, the construct validity of the scale, seeing whether the factor structure and reliability was there among around 500 people who were tested and treated for Lyme disease. And study 2 was an online sample of almost 1,000 people who self-identified as either being healthy or people who suffered from Lyme now, who completed the Horowitz MSIDS questionnaire, which we're now referring to as the HMQ. And we did an outdoor survey activity, seeing whether maybe they weren't participating as much in outdoor activities. And then we looked at convergent validity among components of the scale and seeing whether they linked up with what's called the Big 5 personality characteristics. Do you have obsessive personality characteristics, narcissism, etc.? Right. The last study we did compared a sample of 236 patients who had confirmed Lyme disease, and these were CDC criteria. I had an EM rash, I had a positive ELISA, positive Western blots, with an online sample of a little over 500 healthy individuals. And then we looked at these 3 studies, and what we found is there was convergent validity, divergent validity, and predictive validity. So the key here is that we found out that we could use this screening tool as a validated questionnaire that doctors could give out in their office for Lyme disease. So, for example, we now have people who have chronic fatigue and fibromyalgia in the United States. 5% of the U.S. population has been diagnosed with chronic fatigue and fibro. And as you and I both know, what are the symptoms of fibromyalgia and chronic fatigue? Well, I'm tired, I have pain, I can't fall asleep, my memory's not working, and I might have a little dysautonomia. Well, guess what? Those are exactly the same symptoms as you get with Lyme. So the problem is we don't really know how many of these people really may have Lyme. So you could give this questionnaire out to patients in the medical practices. Similarly, you could have people who are psychiatrists, who have people with anxiety, depression, obsessive compulsive disorder, psychosis, and see if they have a multi-systemic disorder. Do they have physical symptoms? And what we found out on this questionnaire is there was a linking of several different systems that were affected by Lyme, the same ones that we saw from the Shattuck study that was published in the New England Journal of Medicine years ago, which was fatigue, cognitive dysfunction, joint pain and muscle pain, neuropathy with tingling, numbness, and burning, sleep disorders. These were common denominators that showed up in the Shattuck paper from years ago. We found them exactly the same factors in our paper. But what was interesting, which had not yet been published, is that what we found is the people who had migratory joint pain, migratory muscle pain, migratory nerve pain, tingling, numbness, burning, these were very specific for the people who had borreliosis with Lyme disease. So we found that in about 87% of the people, we could see that this would be a difference between those who actually had Lyme disease and those with verified Lyme and those who were healthy. So we made up a table and we basically showed people that this is a discriminatory factor and there were very few other diseases that really cause it.
Yeah, and so and that's what for HMQ when I reviewed the paper, and if anybody out there hasn't gone and looked at the video abstract that Dr. Horowitz posted both on his Facebook page and ours, it's good to review because what I saw was exactly what Dr. Horowitz said. And just to sort of reiterate, I mean, things like neuropathy, that numbness and tingling, cognitive dysfunction, the brain fog, and dysautonomia, which we were talking earlier, and we'll get into a little bit further in the program about dysautonomia, that imbalance and difficulty regulating the autonomic nervous system, and the cardiorespiratory factors. But the big things I think that really stick out that are so important as take-home messages, sort of are this fatigue and then that migratory pain, because I think that those were the two that really jumped out at me from your work. And we see them every day.
And what's interesting is, when you're basically trained as an internist, you learn that there really are not that many things that cause migratory pain. So what I did in table 11 in the paper is I made up a table called MSID's differential diagnosis of migratory pain. And interestingly enough, so if you're a patient, and we were just in Albany for the foundation, we did some blood draws up in Albany at Dr. Stram Center on Wednesday. And what we found is that there were about 300 people who filled out the questionnaire. And interestingly enough, about half of the people or more, when they filled out the questionnaire, had migratory pain. And these were people, some knew they had Lyme, some didn't know if they had Lyme, but migratory pain is seen in very few other diseases, like Crohn's disease. You can get it, for example, if you develop arthritis in, let's say, 20% of Crohn's, you'll only get this migratory pain, basically, if you have active bowel inflammation. If you had gonorrhea, gonococcal arthritis can cause it. But you're not really going to confuse that with Lyme disease, nor with Crohn's, because Crohn's, you're going to have bloody diarrhea, right? Gonococcus, you're going to have a urethritis and discharge. Hepatitis, you can get migratory pain, but again, the liver functions are going to be high. So the only one that I would say is probably the most common one that people might have a problem differentiating would probably be lupus. Acute rheumatic fever can cause it, reactive arthritis, but lupus, the problem is lupus causes a lot of inflammation. You can get a pericarditis, an encephalitis, arthritis, right? So the problem is that you have to know how to differentiate autoimmune disease from Lyme, and that's also in the paper as far as how do you do that, what are the markers for lupus and Lyme. So I think it will be very useful when people realize that the hallmark of Lyme is I have good and bad days, my symptoms come and go, women especially will flare around the menstrual cycle.
Yep.
You have this migratory pain that moves around the body. And then you'll notice if you take antibiotics for an unrelated infection, like a urinary tract infection, you get better or you get worse. Right? Well, so, I mean, that's the hallmark of what we're generally seeing.
And I think you touched on a really important point that I made a note of earlier. Is it Lyme or is it autoimmune? And, I see a ton of patients who present with what appears to be rheumatoid arthritis or what appears to be lupus, but it's kind of got this atypical flavor to it. They might have some of the markers and not quite. And then, and like you were saying, then you start to treat them with whatever modality and they start to get better. Or as happens a lot of times, you'll flare up and then you eventually will get better. But and there also is this sort of piece of infection-induced autoimmune encephalitis and certainly just in general infection-induced autoimmunity. We've had a couple of questions that came up and we'll touch on those. but that talk about anxiety and detox issues. So these are things that I think we can continue to get into as we move further. But in terms of your experience with sort of Lyme causing an autoimmune type of reaction, could you speak to that for a few moments?
It's confusing for some of the docs because Lyme can cause a positive anti-nuclear antibody, and it could look like lupus. And you can get complement deficiencies, which you see in Lyme and in lupus. But the difference with lupus is you need a marker called the double-stranded DNA or Smith antigen, which is positive, which is very highly specific and sensitive for lupus. So Lyme, when you treat the Lyme, and I'm sure you've seen this, Tom, the ANAs will turn negative a lot of times in people, but they're not double-stranded DNA positive. And it's the same with rheumatoid arthritis. We know that there are Borrelia species. For example, in Europe, there's published papers on Borrelia guarini stimulating a rheumatoid arthritis picture. But when you treat Lyme, the rheumatoid factors can get better. But the marker for true rheumatoid arthritis is CCP, cyclic citrulated peptide. Now, where it gets a little bit more complicated is that you're allowed to have an autoimmune disease and get bitten by a tick. And people don't realize sometimes that, two things are possible. So in my new book, How Can I Get Better? I did one of my favorite stories is Brad had Lyme disease, had an autoimmune illness, right? He had rheumatoid arthritis, and he had Bagel's disease. And, what is Bagel's disease? Well, he had rheumatoid arthritis, and he failed multiple rheumatologists. And when I saw him for the first time, and I asked him, what were you on? He said, I was on prednisone, methotrexate, Remicade, Arava, Enbrel. He was on every, DMARD drug and failed it. But he had migratory pain.
Yep.
So the migratory pain told me he had Lyme. When he filled out the HMQ, he had drenching night sweats. And I said to him, well, are you in menopause?
Yep.
And of course, that's my joke for men in their 30s who have, drenching sweats. Is that, of course, Babesia? And then he told me, well, we treated the Lyme and Babesia, and he got much better. But every Sunday, he would eat bagels, lox, and cream cheese, and his knees would swell up to twice the size.
Oh, my God.
So I said, you must have Bagel's disease. But, of course, he was gluten sensitive. And he wasn't staying away from gluten. And once he got off gluten and his allergic foods, and he got, his Lyme and Babesia was treated. Then when we treated his rheumatoid arthritis, the methotrexate worked and he didn't have to go for an operation with a synovectomy. So people need to realize that autoimmune manifestations are extremely common. You can get anti-ganglioside antibodies that you can get an autoimmune neuropathy. You can get a chronic inflammatory demyelinating polyneuropathy, which is an autoimmune manifestation. You can get a positive Cunningham panel with an autoimmune encephalitis, right? So you can get Hashimoto's antibodies that are formed with anti-thyroid antibodies. So Lyme is definitely one of the things driving autoimmunity, as are environmental toxins like mercury, small particle pollution, asbestos, BPA. All of these things have now been linked up. So when you look at 50 million Americans with autoimmune diseases, we got to step back and go, why are all these people getting autoimmune problems? Infections and toxins may be part of the problem.
Right. And I've always, it's always been troubling for me as someone who attempts my best to apply common sense is why is the body attacking itself? There's got to be some sort of trigger to this going on. And, as you're talking about that, I remember one of my first cases early in my career. I saw a young man who, was in early high school, but he had been on methotrexate for juvenile rheumatoid arthritis for years and years and years. But the problem was it didn't do anything. Like his parents were like, it doesn't really help. And so, we treated him initially with a really basic protocol just with doxycycline, and like 80% of his symptoms were gone in 3 months. And then within 6 months, the folks who were seeing him at pediatric rheumatology at a very large, well-known institution in my neck of the woods, took him off of the methotrexate and said that his JRA was caused by Lyme disease, which I thought was good. Kudos to them for changing their diagnosis once they saw it happen. But if we didn't sort of look at it, and in retrospect, this gentleman had migratory pain. He had certain joints that it set into, but he also did have this sort of migratory pattern. So we did have a question about, pain, being more isolated in one or two joints. And certainly I've seen that happen, but there is that pattern of migration, But the other part I think it's important for people to understand is that whether you're using the HMQ or any other sort of diagnostic strategy, like testing, it's a piece of information. It's not just 100%, hey, if I have migratory pain, you have Lyme disease. It's just that statistically, that's one of the things that comes up. And, the other thing that popped up, Rich, as you were talking through that is I've often seen people who are, in their 40s who get Lyme and, it's sort of undiagnosed, and then they've got these symptoms that go on, and all of a sudden they develop, a Hashimoto's or some sort of other thyroid problem. And it's amazing that a lot of times I find we need to do two things, which is treat their thyroid condition acutely, but find out what triggered it out of the blue in somebody where it doesn't make sense. And then you see that as you treat them, a lot of times the thyroid reverses.
Yeah. No, it's a big problem because a lot of the people we see in the overlaps, apart from lupus and rheumatoid, are the MS cases, right?
Absolutely.
I mean, the problem is they get these white spots on their MRI and they get demyelination, and they can have optic neuritis and bladder issues. And basically it can look like MS. And even on a spinal tap, you can get oligoclonal bands and myelin basic protein. So doctors need to understand that Lyme has now been linked up to the autoimmune conditions. We're finding it in dementia, right? I mean, they've now found it in the brains of Alzheimer's patients, along with other bacteria, including chlamydia pneumonia, Helicobacter pylori. There are ones from the mouth. Porphyromonas gingivalis has been found in the brains of Alzheimer's patients from people with gingivitis. We're finding viruses. We need to understand the multifactorial nature of these chronic diseases, which is these infections and toxins. JAMA published 2.5 years ago, and I put this in the new book in the neuro chapter, that they're finding pesticides in the brains of Alzheimer's patients. So what people need to realize is when you're sick, you've got to get to all the underlying sources of inflammation. Because inflammation, whether it's caused by infections or it's caused by environmental toxins or it's caused by the fact that you're not sleeping at night, which happens to Lyme patients all the time, or you have a leaky gut and you have food allergies causing inflammation, or you have mineral deficiencies like zinc causing inflammation, if you don't get to all the sources of inflammation, you're not going to get people better. Because when we looked at chronic fatigue and fibro and Alzheimer's and MS, the common denominator, even autism, are these inflammatory molecules, these cytokines that are produced in all these different diseases. So I think really the reason, I'm kind of excited about the MSIDS map being used not just effectively for Lyme is it may end up being, a possible help for these people with all these other chronic diseases.
Right. And, it's interesting because when I left your office, almost a decade ago after my training there, you were talking about, multiple chronic infectious, disease syndrome, like sort of in its infancy, it seemed like. And the part that I walked out with was not just so much that there's multiple infections, because as you mentioned, optic neuritis, I mean, certainly we've had some people comment on co-infections, and, Bartonella has certainly been seen to cause neuritis, but is that your model doesn't just look at infection. It looks at all these toxins and stressors. And one of the things that I'll be doing in a future Facebook, and certainly, maybe you can join me, but and I'll actually be lecturing at ILADS this coming fall, and this is the brain detoxification system called the glymphatic system, which is actually the system that will drain all this sort of the amyloid that leads to Alzheimer's out of the brain. And one of the things is that it primarily, almost 90% of its work is done while you're in deep sleep. So if we're not sleeping, which, I mean, how many people with Lyme disease are sleeping well? We're actually slowing down that detoxification of the brain. And so there's a lot of work being done. And even something as simple as chlamydia pneumonia, which, is just something that we get by going to the supermarket or going to school, going out with friends for dinner. It's a community-acquired pneumonia bug that has been found in the brains of people with Alzheimer's as well. And a lot of it, and the other thing that's really interesting to me about bringing up chlamydia pneumonia is that a lot of the what we found in the research on chlamydia is that it's actually really hard to treat. And if you give somebody Zithromax for a year or doxycycline for a year, they really can't clear it. You don't have pneumonia anymore, but you can't clear it. So it's not just Lyme and Babesia. I mean, there's a lot of organisms out there that are doing this.
No, and you bring up a great point. And I think this leads into this whole thing on persisters, that has come out from Johns Hopkins University in the last few years from Dr. Zhang. We published several papers on this. Kim Lewis from Northeastern has published on persisters. Eva Shoppe's been looking at some of the persisters being in biofilms. I mean, I think the clear point here is we have seen persisters for Lyme disease. We've seen it with Bartonella. We now have probably, in the last year or two, we probably have at least 15 or 16 people who are Bartonella fish positive, meaning they're RNA positive for BART, despite multiple intracellular infections and treatment. We found that mycoplasma species, I just had a woman, she gave birth to twins, and she was on Zithromax during the pregnancy with Ceftin, which are safe. The amniotic fluid contained mycoplasma, which was PCR positive after 9 months of Zithromax. We've seen cases of tularemia that have persisted. Brucellosis is known to be a persister. Q fever, Coxiella. So what people need to realize is these are intracellular infections, right? And if you don't get into that intracellular compartment, we now know that it's the macrophages, right? And some of these endothelial cells that are containing these intracellular bugs that are driving a lot of the inflammatory process. And that's why the Dapsone protocol and the pyrazinamide protocol, we adapted this from the tuberculosis literature because TB is a persister. And I treated it 30 years ago in residency, treating the HIV population when they came in with tuberculosis. That's where I got the idea of actually publishing these papers on Dapsone and pyrazinamide to see, did it help Lyme patients with co-infections? And in fact, they're quite useful to some of these people that have failed other treatments.
It's remarkable because one of the things I've never understood in whenever you use the word Lyme is all of a sudden the rest of medicine seems to get thrown out, at least in a conventional discussion. It's like, well, TB, like you're saying, there are all these models for persistence, and just as you brought up Brucella, which is something that I actually see a modest amount of. But, in the world literature, you need 3 antibiotics for 18 months to really get above, to get really sort of good treatment responses and cures. I mean, if you use less than that for a shorter duration, you have unacceptable levels of relapse. So one of the things I think, what is your, you've published recently on Dapsone. And I certainly find that that's very useful. I have been using some pyrazinamide in people with some really good results and certainly some really good Herxheimer's. Sort of what's your long-term experience been with those two drugs or what has the experience been at this point?
So, I was in my first 10 years of medical practice when I started doing this, it was kind of like flaming sword in hand. I'm going to kill every one of these buggers, right? And get people better, right? And then I realized, okay, I'm getting the majority better, but it's tough to really knock these things out completely. The next 20 years, the next 10 years, I would probably say I started, working on other parts of the MSIDS model where, for example, we were looking at babesiosis, right? So when you fill out the HMQ, the first question is day sweats, night sweats, chills, right, flushing. So in that second 10 years, I discovered, for example, patients were coming in wheelchairs, unable to walk, drenching sweats, women in their 30s. That's how I discovered Babesia, right, in the Hudson Valley. And we would give, for example, Mepron and Zithromax, and they would walk out of wheelchairs. So, I mean, right, we started discussing the role of Babesia. And then BART, I had a patient who couldn't talk for years who went to Harvard, Mass General. They thought she had some type of an atypical migraine. We didn't know Bartonella was around really causing big problems 18 years ago. We treated her with a quinolone, moxifloxacin, Avelox. She talked for the first time in 4 years. So every year, we would pretty much discover new aspects of the model.
Yep.
And I think what's happened at this point in this third decade is we started realizing that the more intracellular drugs, the better. I think many of us have been using doxycycline and rifampin, or Zithromax and rifampin, right, double intracellulars. But you're right, Tom, with your last comment, the literature is showing that the more intracellular drugs, the better. And that's what I've been finding with Dapsone and pyrazinamide. We've been finding that essentially that the study we did with Eva Shoppe is that doxyrifampin and dapsone was the most effective killing agent against the biofilm forms, these persister forms that are dormant in the biofilms, right? If you give Rocephin, you need actively dividing bugs, right? Flagell, which I had published on years ago, that's for the cystic forms, sometimes called L forms, S forms, cell wall deficient. But then you've got these intracellular ones, and you've got the biofilm. So the biofilm busters that we've now been working on with these persister drugs, we've definitely found that for a certain percentage of these resistant patients, they are improving, but I found that it's not enough for 12 months for some of these drugs like dapsone. We find that now we need to use it for longer, and we're lowering down the load of the organisms, but we're not yet there with a full cure, right? No one has a full cure in the chronic stages, but I must say that once people finish longer courses of dapsone, either 3 or 4 intracellulars, sometimes starting with pyrazinamide the way they do for tuberculosis, 2 months, even 3. I just had a woman on the West Coast. She had resistant neuropathy for most of her life where she could barely wear clothes because the pain was so bad on her chest. And we had to give her intracellular killing agents. Her Bartonella fish was positive after years of treatment.
Right.
She's now responding to a 3rd month of pyrazinamide. She did a lot of rifampin, even IV, tetracyclines with macrolides, even gentamicin, and now she's off morphine. She went from 100 milligrams of morphine down to 5 milligrams of oxycodone, which she's been reliant on because it was Bartonella that was causing the resistant pain. So, longer-term treatments with multiple drugs in combo, that's really what drove me to write this second book, How Can I Get Better, is we found all of these different treatment protocols working, and I wanted to get it out to the community for the doctors and patients so they could also get the same help that I was seeing my patients get.
Right. Well, and one of the questions we got was what you mentioned for treatment of Babesia, and I think if I heard you correctly, sort of the basic places to start are Mepron and azithromycin. But then you brought up talking about persisters and biofilms, and the work on biofilms is something that I think is key in what we do, and it sort of dovetails with the question of babesiosis. I know there's a lot of things that you work on and you have listed in your outline, so I'm not going to steal the thunder on that one. I'll let you address that one. But one of the things I use a lot of with is artemisinin in a liposomal form, which I find is very helpful, both in absorbability out of the gastrointestinal tract, but then also it seems to kind of be like a Trojan horse for these biofilms. But also, artemisinin is a pretty potent anti-Babesia, anti-malarial herb. So, what are the other things that you're finding are helpful in these in the biofilm area?
So for the biofilms, we started using serpeptase years ago because it both hit the formation of biofilms and the biofilms that were already around. But we're now mixing multiple biofilm busters, like we're mixing lauricidin, monolaurin. So it's a coconut oil extract, and the nice part is it hits not only the biofilms but different forms of Lyme, and this has been published in the medical literature. You'll find the references, in fact, in the back of my book. We're using stevia. So Eva Shoppe had done some of the initial studies on stevia, and she found that the Nutrimetics blend, at least 15 drops twice a day, was effectively hitting biofilms and different forms of Lyme. The biocidin protocol, which is going to be published from the University of Finland, that has shown some effectiveness. And also what's nice is some of these also hit candida in the gut, like monolaurin and biocidin. Mm-hmm. So we're using combinations, and in fact, I've asked Eva to go to the lab and put different biofilm busters in combination to see if we can, find other ones. But some people are using EDTA and other ones to get at it. But I think the key is for people that have not gotten better, there are the cell wall forms of Lyme, the cystic forms, the intracellular forms, and the biofilm. So the key is, if you've not treated all the forms, everybody's different. Some people love bicillin and long-acting cell wall drugs. Yep. Some people don't respond to cell wall drugs like bicillin or Rocephin. They do really well with intracellular drugs. So the key is you've got to individualize the treatment. And I put in, this new book, the 7-point action plan for what I'm doing. And the first is Symptoms drive diagnosis and treatment. If you have active day sweats, night sweats, chills, and flushing, and you have done a differential diagnosis ruling out brucella and hyperthyroidism and malaria and tuberculosis and non-Hodgkin's lymphoma and all the things that cause sweats, Babesia is a persister. You've got to use artemisia and cryptolepis and neem and rotate in clindamycin with Mepron Zithromax, maybe with Bactrim or Dapsone. If you read my books, you'll find all the drugs and the herbs that we use in combination because Babesia is a persister, as is the infections like Lyme, BART, Mycoplasma. So the trick here is that you've got to get and listen to the patients. What are they responding to, right, as far as how they get better? And you're right, Tom. I mean, artemisia and herbs, the Cowden protocol is effective in about 70% of the people. We found the traditional Chinese herb from Zhang to be effective in about 70%. The Byron White protocol, the McCamish, Booner's protocol.
Beyond balance,
there's no one right way. People have to basically try some of these things out and, see what works for them. But we do mix the antibiotics and the herbs to kind of a maximum effect. Right.
And I touch on this topic a lot. I get asked it in public and also, patients in the office. And, I have some people who seek me out just to do straight up herbal treatments, and try to stay as natural as possible. But I think most of my patients, over 80%, really need that combination of sort of medications, could be antibiotics, antiparasitics, antifungals, and also the herbal approaches. And then, one of the things that I think is super important, and we had some questions on, was, diet. So I was hoping we could spend a minute maybe talking about a couple things. One is, what about people who can't tolerate medicines, and why do we think that might be happening? And then what are the other things that we do? Because I think we approach these fairly similarly. What are the other approaches that actually allow us to address the thing? Because I guess for me, then we even had a question too about, your MTHFR status and detox. And, I was watching a really cool video from a gentleman by the name of Ben Lynch the other night, who talks about like the importance of understanding that because he's sort of a genetics scholar guy, but talking about how the sort of the genetics or the infection being expressed through an individual and their individual environment, which includes their external environment, which could be the mycotoxins, the EMF exposures, but also their internal environment, which has so much to do with their diet. So maybe you could take us down that path.
Sure. So again, the key when you want to get people better, the first point is symptoms drive diagnosis and treatment. The second is lower inflammation. Now, diet, when your diet is off, and that's actually rule 6 on the 7-point action plan that I have and how can I get better. Rule 6 is you've got to look at sleep, you've got to look at your diet, and you've got to look at exercise, right? So the thing about diet that's important for people to realize is diet plays an absolute huge effect in people who have this disease. The bugs love sugar. One of the first things you need to do is you need to get off all of your sugars, both simple carbs, some people even complex in the beginning, or really lower it down. And you've got to be able to lower down the sugars. You've got to get all your allergic foods out of the diet. You've got to be able to make sure these people are not gluten sensitive and try trials off gluten. Some of them need to also try off the nightshade family. We see a whole group of people that are histamine sensitive. So they have mast cell disorder or mast cell activation. So with diet, half of America has hypoglycemia and metabolic syndrome. The sugars will swing their blood sugar with insulin resistance. That causes inflammation. And as we talked about, inflammation is the #1 underlying cause of why people stay ill with chronic disease. So if you don't get the microbiome of the gut in order and you're not eating the right diet, if you're eating allergic foods and gluten or histamine, sugar, not following a paleo/ketogenic Mediterranean style diet, making sure you don't have leaky gut by seeing if your zonulin levels are up, right? You've got to make sure your diet and the gut are in good shape because it deals with detoxification. It's your first line of defense for your immune system. So yes, the diet is absolutely essential, but so is sleep. If you don't fall asleep, inflammation is going to be there, right?
Right.
So people need to realize that if they go to the 16-point MSIDS model, I saw one of the questions come up, I'm not getting better, what do I do? I always go back to the 16-point MSIDS map and I go, what haven't I done? The Lyme will affect, basically at this point, the hormones. 40% have low adrenals. If your adrenals are low, you're not going to get better. If you have POTS dysautonomia, right, you have low blood pressure, right, you're not going to get better. And a great example, a woman contacts me on Facebook several years ago and says, my daughter's in a wheelchair, she's seizing, she's seen 4 infectious disease and 4 neurologists in the South, and she's dying. She's on morphine, 480 milligrams with pain. They can't control her seizures. She can't eat. She can't poop. She can't go to school. She's literally dying. And she says to me, if you don't see my daughter, she's going to die. And it's like, I've had Jewish guilt from my mother, but, that's not the kind of guilt you generally want to throw onto a physician. Well, okay, she flew up. This was years ago when I was, taking patients. And I gave her the HMQ. She's 15 years old. The first question was, do you have drenching night sweats, day sweats? She said yes. I said, okay, that's probably babesia. I said, with your pain, you're on morphine. I said, is it migratory? She said, how do you know? I said, well, that's probably Lyme. I then picked up her shirt and she had stretch marks all over her body, suggestive of Bartonella. And then we tried standing her out of the wheelchair. Her pulse was 90 over. Her pulse was 90 with a blood pressure of 90 over 60. She stood up, and you couldn't get a blood pressure, and her pulse rate went up to like 130. She had POTS. So without even doing a test, just by examining the patient, taking a history, and doing a physical, we suspected she had Lyme, babesia, Bartonella, and POTS. 4 nails on the MSIDS map. I gave her doxy and rifampin for the Lyme and the Bartonella. I gave her artemisia and malarone for the babesia. I gave her salt, licorice, and florinef to raise her blood pressure. And 1 month later, she comes in off morphine, no pain, walking out of a wheelchair with absolutely no symptoms whatsoever. Now, it was just taking a history and doing a physical and using the MSIDS, the HMQ to screen and figure out what points on the MSIDS map are making you sick.
I think that's really what's really important to highlight here too is the actual fact that we sit down with patients and we listen to their story, and then we do a differential diagnosis, and we look at all of medicine, including these possibilities of these tick-borne infections. Because when I went to medical school, they said if you sit down and you listen to your patient, don't interrupt them for 5 minutes. 90% of the time, they'll tell you what's wrong and how to fix them. And I think that the tool that you've provided the medical community and even patients, because they can use it on themselves, is a way to systematically, go through that, And another thing that struck me is in that story is that this girl, like, we're treating her pain with so much morphine that now she can't poop. So she can't poop, she can't detoxify well. She can't, her immune system, if 70% of our immune cells are living in the gut wall, well, now your immune system is going to be, functionally suppressed. And then if we go back and we look at what the microbiome does when we're overweight, our microbiome changes. If we don't sleep, our microbiome changes. If we're on certain medicines, our microbiome changes. And then we increase the level of inflammation in our body. I mean, there's so many studies on this. So, we've had a couple of questions pop up that go along the same lines for me, and particularly with gut health. And I agree with you, a paleo keto style diet for a lot of reasons. And in fact, I have some guests lined up who are going to help us talk about these in weeks to come, which I hope that'll be helpful for some of our viewers today. But I find that mold toxins and really are one of the things that a lot of us aren't looking at, or we don't know how to treat effectively. And part of that is, I think, some of that testing is a little on the expensive side, and some of it, we have 2 major models that people sort of that are out there that doctors are learning. And I find that the colleagues of mine who do the best and the best results I have is sort of mixing those together. And also with the understanding that the mold is a fungus and candida and other yeast are fungi as well. So these are all things that are impacting our gut. So I was wondering what your experience is with sort of, the SIRS model, the mycotoxin, biotoxin model, and how that plays a role in your MSIDS model.
Yeah, so one of the points on the MSIDS map, I believe it's 4, is basically looking at environmental toxins. And when I was first doing studies years ago, we were finding a large number of people had heavy metals like mercury and lead. Why is mercury important? Well, if you look at mercury toxicity, it actually causes every symptom you see with Lyme. You can get fatigue, neuropathy, brain fog, psychiatric issues. You get all of it, right? So about 20 to 25% of our patients, when you detox mercury or lead or arsenic, which cause, inflammation in the body, also cause neuropathy, these people basically get better. So when you look at then mold, we find about 2/3 of our patients are now testing positive for mold toxins, aflatoxins, ochratoxins, trichothecenes, and the last one we're showing up now is gliotoxins. So you've got to look at all of these because, and especially gliotoxins, which concerns me, is because it's immunosuppressive. And as you know, these bugs we're getting, Lyme causes effects on the immune system. Babesia can affect the way you clear other infections like parasites. Same with Bartonella, right? And then you've got Lyme affecting the immunoglobulins, where a lot of our patients come in with chronic variable immune deficiency. They have low immunoglobulins, low subclasses. These are the ones that hurts the worst, that basically have like a lot of autoimmune encephalopathy. They're the ones that get the small fiber biopsies back, when they do nerve biopsies. So, all of these things are affecting your immune system. Mercury and lead and mold toxins, right? So we have to keep in mind that all of these things at once are affecting the way our immune system is, and as you mentioned, even the microbiome of the gut. We now know that depending on how many Prevotella species you have in the gut, or Clostridia or other ones, you're going to have a higher risk for autoimmune disease like MS, rheumatoid arthritis. So all of these things are now playing a role, and we detox people. I don't do it IV, I just do it orally. And I have in the back of my new book, How Can I Get Better, an addendum which has all of the protocols that I use, including dosages. So in there I have, for example, oral phosphatidylcholine, 3 grams twice a day, using, for example, a liposomal glutathione, using toxin binders, whether it's cholestyramine or Welchol or clay charcoal. What's nice about this is that when we combine these detox regimens, like using infrared saunas, and flushing through the kidneys and supporting the gut, right? And opening up the phase 1, phase 2 detox pathways in the liver. We find that a large number of people get better. So for those out there who are listening who say, I'm not getting better, I've treated the infections, you have to remember that it's both infections and toxins that are causing a lot of these type of problems in people. And a great example of the toxins is one of my patients several years ago, computer specialist, came in. He couldn't work at all. He was watching Netflix reruns for 2 years in a dark room. He was light sensitive. And he came into my office and I gave him a shot of glutathione. And he got 2,000 milligrams. And within 15 minutes, his brain woke up and it actually never went back. Now, these are unusual stories, but they highlight like the importance of these neurotoxins, because Lyme can also cause quinolinic acid to form and other toxins, as well as these external toxins. So infections and toxins are very important because they drive the inflammatory response in the body. So you've got to therefore go to this 16-point MSIDS map that's discussed in both of my books. Keep going through it piece by piece. Are your hormones off? Do you have POTS? Is your diet off? Do I have food allergies? Have I missed the Bartonella? Have I not adequately treated the Babesia? I mean, it sounds complicated, but if you really do it piece by piece, we have found that probably the top 6 points is treating the infections, getting rid of those toxins, dealing with the inflammation, getting people to sleep, getting the POTS, in order, and probably balancing the hormones, because a lot of these people, men come in with low testosterone, the adrenals are off, the thyroids are off. Those 6 ones are probably the most important points that have, the greatest effect on getting people better.
Yeah, and from my perspective as an osteopath who's trained to look at the interrelationship between the structure and the function of the body, as well as, the body having the ability to heal itself, is, we need to sort of look at the whole picture and find out where the primary problem is at the moment. And I think that I've heard you over and over again say, go through the model, do our 16, but we might have to go through it and through it and through it because things are going to change. We've had several questions about, hey, I've got Rocky Mountain spotted fever and candida. I've had Lyme since I was 9. I've had, I have issues with lead or mold or this thing. And, I'm always trying to figure out, I always say, like, hey, if there's 20 things going wrong with your body and I'm treating number 4, number 5, and number 6, you're never going to get better. But I have to try to figure out, and I think that your model does a nice job of that, is what is like you said earlier, what is the patient walking in with today, and what are number 1, number 2, number 3 issues for the body? And there's a little story I wanted to tell because people are always asking, what can I do extra? I'm working with a good doc, but I need more, or I can't get in to see a doc at the moment, the waiting list is too long, or what have you. What can I do? Or better yet, what can I do now to prevent myself from getting sick later on, or have the best chance if, God forbid, I ever got, bitten by a tick I could do? And one of the things I went to a conference and I learned about the negative impacts of the electromagnetic fields around us, particularly about Wi-Fi. And so I sleep really well, generally speaking. And what I did was I went home and I turned off my Wi-Fi at night. And then I was unable to sleep for about 2 weeks with the Wi-Fi off. And so then everything went back to normal. And a couple weeks later, I had one night where I couldn't sleep. And a couple weeks later, I had another night. And this went on several times. And then eventually I go, in the middle of the night, I'm like, why am I not sleeping? And I actually went back downstairs and my Wi-Fi was on. So what I believe happened was I was actually initially not sleeping as I was detoxifying from the Wi-Fi. And then whenever it's on, I can't sleep. So now we have a rule that we only turn on the Wi-Fi if we absolutely need it. And any computer that's able to be hardwired in my house is. So we are in a world where there are these toxins we can't get away from, but we certainly can minimize that. And I think things like turning off your Wi-Fi, things like, doing generally a paleo type of diet are going to be really helpful. And then I really encourage people to go out and, take a look at Dr. Horowitz's books, because the map is all there. But I think the thing to remember is you don't need to do every single thing at one time, and everything in the book may not be applicable to you. So, but it's a great guideline. And I just want to reiterate again, Dr. Horowitz has been talking about, going through and making a choice of what you do, and then you reassess the patient, and then we go back through that model again, and we just continually go through it. And this is traditional medicine that's worked for thousands of years, is to talk to our patients and do that. So, Rich, I was hoping in the time that we have left, because I know we're approaching the hour mark here, if you could talk a little bit about, what you're doing in terms of folks who come in who really are just blowing up on every sort of medication protocol you give them. And what are sort of the real take-homes, in terms of, can I get things done herbally, or what are the tricks to unlock it so that maybe they can get those appropriate treatments?
That's a great question. So the key to all of this really is you've got to lower inflammation. Whether the inflammation's coming from infections, whether it's coming from environmental toxins, whether it's coming from leaky gut and eating the wrong foods, whether it's from a sleep problem, the key is you've got to lower inflammation. So let me go through a little bit, because the worst people who really come to me are the ones who herx. The minute you throw an antibiotic at them, especially intracellulars, they're herxing, for days or weeks. We call them affectionately our herx queens and our herx kings, right? Yep.
Yeah, it's like you say Zithromax and they flare.
Yeah. So that means, by the way, if you and understand what this means in a patient, if you flare from Zithromax, an intracellular drug. If you flare from doxycycline, an intracellular drug. Yeah. If you flare from rifampin, an intracellular drug. If you flare from a quinolone like Cipro or Levaquin, an intracellular drug. Where does that mean the bugs are? Intracellular. So the point being, the regimens we now put together to help people are multiple intracellular drugs together, and it's laid out in the new book, How Can I Get Better? But here's the key. You can lower inflammation by shutting down a switch, which is inside the cells of the nucleus called NF-kappa B. The way you do this is by stimulating something inside your cells called NRF2 to go into your cells and shut down an inflammatory response. So you can block this switch inside the nucleus called NF-kappa B by doing certain things like low-dose naltrexone. This blocks NF-kappa B. This shuts down these small cells in your brain called microglial cells that cause inflammation. You can do an anti-inflammatory Mediterranean/ketogenic paleo diet. You're upping your omega-3 fatty acids, right? And decreasing arachidonic acid. You're getting off your allergic sensitive foods. You're reducing your simple sugars, daring off dairy, gluten, and histamine. You're replacing the minerals like zinc, which deals with inflammation, magnesium, which deals with how you detox, copper, which you need to handle free radicals and oxidative stress. You're getting proper sleep and exercise. You're treating all the infections, which are mainly Lyme, Babesia, and Bartonella for the majority of people, to make this simple. And even if you had mycoplasma and chlamydia and Brucella and tularemia, fortunately, many of these triple combos we're using will go after all of these bugs at the same point, and that's what we're trying to do. You then have to open up the detoxification system, get the chemicals out of your environment, sometimes get the EMFs out if if you happen to be one of these chemically sensitive people, and we do see them. You got to balance the hormones. You've got to balance the cytokines and the microbiome, heal the damage to the body, which is the mitochondria, because all of these free radicals are damaging the sensitive cells in our body, which help you with energy, cardiovascular function, neurological function. So you've got to heal that with mitochondrial support. And then those of us who have also had very difficult childhoods and trauma, it's sometimes about healing those emotional wounds, because sometimes people have emotional wounding and it's almost like their immune system is wired not to get better. So the key here is the 3 I's: infections, immune dysfunction, and inflammation, going through all of those things that lower down inflammation. But as you said, Tom, you've got to figure out and prioritize what the biggest factors are in your healing, and that you can do with most people if you take it step by step.
Right. And I think some of the important things for me too is that, we do have a lot we can do for ourselves here, like you were saying. I mean, I find it really interesting. We talk about the body, mind, spirit connection and all this, but really that's just one thing. That's us. We use words to break those 3 things apart, so it's easy to talk about. But if we do have things in our past, like you brought up, we really do need to work on those, and that can help support our immune system. Simple things, like breathing exercises are going to, it's interesting when I go back to the very beginning, how you're saying, hey, at the Kripalu retreat, in December, you're going to be having meditation. Well, here's the reason why. I mean, it's so important to find the way to center yourself and support your immune system. And there are all these cool things that we can do for ourselves. So, there are so many things that we could continue to talk about, but I think that we're getting close to the end here. Before we sign off, Rich, could you sort of just, remind folks where you're going to be over the next couple of months, and, make sure that those who are just joining us can hear that again?
Sure. So I'm going to be next month in Chicago at the Second World Conference on Immunology. I'll be the keynote speaker there on October 9th. Tom and I will both be at ILADS in Boston, and that's always a great conference to learn, and I encourage people, if you've not been to ILADS, wonderful conference, several days. There'll be a 1-day also pre-conference for people who are new to it, and one actually for the patients that I'll be speaking at. And then finally, I have a rare opportunity to do a 3-day weekend workshop, Friday through Sunday, at Kripalu, which is in Lenox, Massachusetts. It's December 2nd to 4th. It's both physicians and healthcare practitioners and patients. And we have an ongoing question and answer the entire weekend. People can bring case studies. It's a great weekend for really getting the download, learning. So I want to finish off, Tom, and just let people know, because I'm watching the questions come across, there is hope, right?
Yeah.
You should never give up. And after doing this for now, more than 3 decades, if you do go through the 16-point MSIDS map and you look at some of these new studies that have come out on persisters and on biofilms and on some of the toxins and the gut and everything we've been talking about, and it's all laid out in the books. You can work with your healthcare providers. That's why I've written these books, so that you can get help, but just know you should never give up. There is hope. We are getting the majority of the patients better. And I also want to put out just a plug that if for any healthcare practitioners out there listening to this, I need help. Please join my practice. We got a worldwide epidemic going on. And by the way, I've tried to pull Tom into my practice, but he won't leave Connecticut because he and I have a great time together and we'd be great together. Yeah. So anybody listening, if you have an interest in saving the world, please let us know because we're looking for practitioners. Please contact us.
Oh, yeah. Well, I appreciate you saying that because I'm in the same boat. You know, it's just like we need more people that we can train up to do this work. But I really want to echo what Dr. Horowitz is saying, is that there really is hope, and not to give up. You know, over the next weeks and months, I hope to be bringing on other guests, and hopefully Dr. Horowitz will be back. Before we came on the air, I said we need to talk. He was saying we need to talk about co-infections. I'm like, yep. That'll take about 5 more of these, and there's a lot of information out there. But I think the take-home points really are the 3 I's that Dr. Horowitz stated, infection, inflammation, and immune function. And, the other thing is you need to just start somewhere and take the first step. And, I think that as providers, we're all going to use our own personal sort of style in what we do. But I think that, so many more people need to be looking at the 16-point differential diagnosis and that map. And I think one of the things that I'm most passionate about is to get validated information out there to doctors so that they don't, because a lot of times you go to your primary care provider or your specialist and they're interested. They've heard Lyme can be bad, but they've also heard, that there's some conflicting sort of information out there. But now we have this model where you can use the HMQ. It's validated. It's published in the medical literature. And you can hand them a paper. You can even, do the questionnaire yourself and hand it to them. And now you have scientifically, medically validated information that really can help get more people, more providers interested in doing what we need to do. And then maybe you gift them a book, that Dr. Horowitz wrote. That could also be helpful. So certainly, thank you everyone for joining us. I mean, I've been watching the numbers of folks here, and it's for this morning, it's remarkable. We really are very honored and privileged to have you all out there. And we're gonna, in the comments below, let us know if there are other topics. I know there's a lot of people, who have been talking about different things like mast cell activation and more specifics on herbals and what do I do in this situation or that situation. So we'll certainly be looking at all those comments and seeing what we can do for future programs. Again, Dr. Horowitz, thank you so much for making the time to do this for everyone. And everybody have a great day.
Yes. Thank you, Tom, for doing this. And I wish everyone well.
Be well, everyone.
Okay.